Hello everyone, my name is Kelsey Walker. I will complete my doctoral program in 3 weeks. I am graduating with a primary pediatric concentration, and I wanted to thank you for listening to my presentation, which is titled Improving Parental Advocacy in Pediatric Settings. It is very close to my heart at this point. So I will get started. Slide 1 shows my topic name. Advocacy, a fundamental right in healthcare, aligns with healthcare workers' responsibility to uphold the moral principle of patient advocacy. The significance of this concept was illuminated after I spoke with a frustrated and frightened mother standing at the bedside of her encephalopathic newborn. The mother recalled taking her child to the primary care provider and emergency department on 3 separate days with concerns for her febrile infant who was not acting like herself. She was sent home twice with her child before being admitted to the pediatric intensive care unit, only to find that the patient had been experiencing subclinical febrile seizures, which had resulted in possibly irrevocable brain damage. In pediatric acute care settings, parental concerns should be respected and valued as potential indicators of impending decline. Clinicians have a duty to actively collaborate with parents regarding the state of the patient, their child. I included this image in slide 1 to represent collaboration. While it's difficult to quantify, research has shown that parents experience feelings of powerlessness when they cannot convey their concerns for their child during a healthcare encounter. For example, a patient or legal guardian may experience frustration if they described an intervention that improved their child's health in the past that is not being utilized during their current admission due to the healthcare team's choices. It is crucial to decrease feelings of powerlessness and promote the parent's role as advocate for their child. Through my clinical and work experiences, I have learned that the healthcare team should be intentional regarding explaining their methods because an explanation goes a long way when collaborating. Slide 1 states parental advocacy improves pediatric patient outcomes. Parents explain frustrations to the nursing staff regarding feeling a lack of collaboration, and research lacks tools to improve parental advocacy, and that is where my project came in. My PICO question states, it was selected based on an eyewitness experience with parents and patients, as I stated previously. The PICO question is as follows. In parents or legal guardians of pediatric patients who are receiving an advocacy how-to information sheet at admission, compared to verbal encouragement of advocacy, increase a parent's or legal guardian's perception of having input in the healthcare provided to the child? Initially, it was difficult to think of an intervention that would directly or indirectly measure advocacy. As I talked through the PICO with members at my institution, I decided to implement a tool called the Care Pyramid, which I will explain in detail. With this project, I hope to teach frightened and frustrated parents how to advocate for their children. The goal was to see parents' comfort with advocating increase so that the healthcare team could best serve their child. Sometimes preventable harm occurs when parents or caregivers do not share their concerns, input, or questions. Withholding input and questions inhibits the acquisition of knowledge related to the patient's medical diagnosis. I conducted a qualitative study. The how-to tool I utilized was the Care Pyramid, pictured on the right of this slide. This tool was a color-coded visualization with examples of questions parents could ask to be involved and things they could do to participate based on the patient's acuity. The blue tier at the top represents patients who are ready to be discharged home or transferred out of the ICU where the project took place. The red tier on the bottom represents patients who are very critically ill and unstable. The tool's purpose was to give parents who may be feeling overwhelmed ideas regarding how to navigate their stay and be a valued member of the patient's team. After speaking to Maryville University's statistician, whom I am very grateful for, we determined that I should conduct a z-test for the difference of two proportions. We selected this test because I would be conducting a retrospective data search comparing survey results prior to and after the implementation of the care pyramid. The steps of the project were as follows. 1. I was to conduct a retrospective data search, including input from a 3-month span prior to the intervention. So this retrospective data search included data from November 2023 to January 2024. Next, the tool was printed, laminated, and posted in each patient room on my unit, which is about 50 beds. 3. The nursing staff was educated regarding the purpose of the tool, and they were implored to teach patients and parents of the tool upon admission to the PICU, or the Pediatric Intensive Care Unit. 4th, the managerial staff conducted random parent audits to assess nursing compliance with providing education regarding the care pyramid. Lastly, post-intervention data was obtained, and this happened from April 2024 to May 2024. I utilized survey data during this project to gauge parental advocacy. The surveys were sent to parents upon discharge from the PICU to home. The parents are asked multiple questions on the discharge surveys, but the two reviewed during this study asked 1, did you have enough input or say in your care? And it also asked, did the nurses listen carefully to you? My sample consisted of 22 and 21 participants, respectively. Again, 2 questions were asked. The first was, did you have enough input or say in your care? And the other was, did the nurses listen carefully to you? To reach a statistically significant result for a z-test for the difference of 2 proportions, a sample of 30 would have been necessary. I conducted a retrospective search through Power BI, the statistical software which collected the survey data at the institution that I completed my project. The retrospective search included input from a 3-month span prior to the intervention. So this took place in November 2023 to January 2024. For the question, did you have enough input or say in your care? 19 out of 22 answered yes, definitely, prior to the intervention. For the question, did the nurses listen carefully to you? 21 of 22 answered yes, definitely, prior to the intervention. My institution underwent a security breach during the data collection period. Therefore, post-intervention survey results were collected for 1 month rather than 3 months, as was recorded prior to the intervention. 15 of 21 respondents answered yes, definitely to the question, did you have enough input or say in your care after the intervention? Due to a sample size of less than 30, there was not sufficient information to suggest parents of discharged PICU patients felt they had enough input or say in their child's care pre to post intervention, where the Z equaled negative 1.2034 and P equaled 0.8856. 15 of 22 responded yes, definitely to the question, did the nurses listen carefully to you? after the intervention. Due to a sample of less than 30, there was insufficient information to suggest parents of discharged PICU patients felt the nurses listened more carefully to them pre to post intervention. For this question, Z equaled negative 2.3452 and P equaled 0.9905. For the purpose of this study, the results did not suggest that parents of discharged PICU patients felt more comfortable advocating for their child, the patient, after the implementation of the care pyramid, or that their skills with the concept of advocacy had improved. The PICU management team conducted parent audits as their time permitted, inquiring about whether the nursing staff had explained the care pyramid to the parents upon admission or during some point of their stay up until the point of the audit. The audits revealed that of the 15 parents audited, only one had been taught about the care pyramid by the nursing staff. The 6% compliance rate by the nursing staff may correlate with the decreased percentages post-intervention. As previously mentioned, there was insufficient data to conclude that the care pyramid improved parents' ability to advocate for their child. The raw data, however, revealed a decline in parents reporting they had enough input in their child's care and reporting a decline in nurses listening carefully to them. The parent audits provided key information which demonstrated that there was a poor compliance rate of only 6% of the nursing staff explaining the tool to the parents. While it was disappointing to see that the tool did not have a positive or significant effect, I was grateful to have implemented the parent audits because they shined a light on the need to incentivize the nursing staff to provide extra layers of education. One can infer from my study that supporting nurses is likely an essential component of supporting parents, which is understandable because nurses have the difficult task of juggling many layers. Due to the results from this project, committees on my unit and within the institution are prioritizing strategies to improve the experience of parents and patients. Further research may be best served to prioritize implementing tools that directly affect the parent by giving the tools to the nursing by giving the tools to the parent or administering survey cards to parents upon admission, rather than posting the intervention in the room and relying solely on the nursing staff to educate the families in this regard. I am grateful to have had the opportunity to implement this scholarly project. This project and process was difficult, but I am proud to say that I completed it, regardless of the results. Thank you all for watching this presentation.